Hi, everyone, and welcome to What to Do When the Payer Says No. I'm Deb Silverman, the chair of the Managed Care Group at Garfunkel Wild. I'm very excited to moderate this panel for you today. We have a really great panel, the best in the business, in my opinion, and that includes Karim Habibi, Senior Vice President and Chief of Managed Care at NYU, Kwynn Smith, Vice President, Payor Contracting, Mount Sinai, and Jeff Pogany, President, Pogany Managed Care Consulting. We'll talk a little bit more about our panelists in a minute, but first, let's talk about the changing landscape when it comes to managed care contracting. You'll see from my slide, as payers increasingly seek to maximize their bottom line, it has made for an environment that creates much tougher contract negotiations. During the course of a contract, we see payers implement policies that have a net effect of decreasing the revenue that you expected to receive from a contract at the time you inked it. Upon contract renewal, payers start their negotiations with a proposal that doesn't include a rate increase. It doesn't even include a modest rate increase. It includes a rate reduction. Doesn't set the conversation off on a good note. We're also seeing many times where the payers will send new templates, and those templates contain much more restrictive language that doesn't benefit the provider. So first, a bit about our conversation today. It's a process. We've looked at it in 4 different tranches, and one can blur into another, but for purposes of today, we want to kind of keep our panelists on a path forward. It starts with assessing your current situation. What leverage do you have in the marketplace? How does the payer see you? What do you need to accomplish, which is then part of your negotiation strategy? You also need to manage your expectations, both internally with respect to your own organization and with the payer themselves. Are you asking for a couple of items, or are you throwing the kitchen sink at the payer? And then, of course, the actual process of negotiation. And to help us with this conversation today, we have Karim, who's got a wealth of experience. He's been doing this for about as long as I have. And he too has seen, and we'll talk about the transition of how it used to be, perhaps when we used to negotiate contracts. You always felt like you had a bit of a partnership with the health plan, to where we are today. Next, we have Kwynn. Kwynn has had experience both at Montefiore and at Mount Sinai, where he continues as Vice President of Payer Contracting, and has a wealth of experience to share with us. And last but not least, we have Jeff Pogany. Jeff is now a consultant in this space, but I have to tell you, Jeff's background is probably most impactful for those of you who don't have major health systems behind you. Jeff brings experience as working for United Healthcare, so he's got that payer perspective, and he's also got the perspective of dealing with the big health system, like when he was at Montefiore. And now he does a lot of work consulting with the little guys, practices, physician practices, community hospitals that really don't come to the table with the same kind of leverage that an academic medical center has. So with that, let's start our conversation. And this is my slide in case you want to go back and take a look. Okay. Assessing your current situation. What is your value proposition in the market? Karim, why don't I start with you?
Good afternoon. I think I would focus first on how important is the health system to corporate employers, unions, and the public in the existing marketplace. That also should be reflected in the market share that we drive as a health system, size of the network, both employed physicians as well as the number of hospitals and the geographic coverage. Quality is very important to the NYU Langone Health System. We pride ourselves, we shoot to be the highest quality not only locally, but also in the country, measured by CMS, Leapfrog, US News, and Vizient. Vizient is an entity to which all academic medical centers in the country where they participate in and and send their data, claims data into them, and they basically aggregate the data and calculate different quality measures and efficiency measures on every health system. So basically, we want to be a high-performing health system in both quality and efficiency. We also look at how we're performing in our value-based contract with the existing contracted plans. So that's another important area in terms of how we're performing quality-wise and efficiency-wise in terms of admissions per thousand, ER visits per thousand, readmission rates, so that we can move the conversation from unit cost specifically into total cost of care. And based on the quality and efficiency that we're producing, the request is to get compensated adequately relative to that.
Kwynn, does Mount Sinai do things differently?
I think Karim really hit on a lot of the key points in when you're looking at your current situation, what's your value proposition in the marketplace. You definitely need to understand who the ultimate purchasers are of the products that are out in the marketplace based upon the line of business that health plan or payer is contracting for. You need to dissect that into how they are performing today and get that down to the plan sponsor level. Not all plan sponsors act in the same way or products act in the same way as in them complying or your contract yield. So we add in the contract yield of basically looking and saying, if they were performing at 100% and paying the contract as written, what are we achieving? Where are they trying to take advantage of loopholes in the contract? By line of business, where are they operating? Because within a single payer, you can have multiple areas of products that really are hidden. You have your ASO, self-insured, ERISA, Taft-Hartley aspects. That's a majority of the payers in our commercial payers in our marketplace. You have the fully insured. You then have them renting their networks in the TPA marketplace, and then you even have some of the payers in the marketplace with their international lines of business. Segregating down into those and then driving into who are the plan sponsors, the employer groups, or who are the TPAs, who are the international payers accessing your contracts, and how are they performing, really can be enlightening in developing your strategy, developing what is your value proposition to the payer.
So let me cut you off there because we're going to get to the negotiation strategy in a second. Let me throw it to Jeff to ask him about how do you develop, let's say, a negotiation strategy. What's your assessing your current situation. Kwynn, you threw me off there. Assessing your current situation for, let's say, a small community hospital, and then maybe you could pivot and talk about for a physician group.
Yeah, perfect. And I, having been through the Montpelier experience, I think both Karim and Kwynn hit on really the salient points of being a large academic medical center. From the experience today, the community hospitals, you all know them. They're the smaller, maybe mostly Medicaid, live in a certain space. They don't, not affiliated with the large academic centers around New York. So I have a few of them. I will say that depending on their payer mix, oftentimes they are what we'll call a lower cost provider, but that doesn't mean as much other than they are potentially known for their ED, right? A lot of the commercial volume that comes to these folks is usually ED. They're not doing a ton of outpatient work potentially. So they're still a vital resource in the community. And usually they are the only resource in that community. And what your value prop is that you are the provider of record for so many patients that rely on a community provider. And that can be really under the shadows of a very large health system in the Bronx or in areas of Far Rockaway and Queens. And so where you have these providers, you don't have a ton that you can push. And termination is a tough thing to do for a lot of reasons, and we can talk about that strategy later. But really, you have to focus on what you're bringing to the community. You have to focus on and again, this goes into strategy, and I'm sure Kwynn and Karim will also speak to this, but knowing what other payers are paying you, right? And so you'll have to start thinking about what your value is to all the payers. Looking at your volume, looking at things that are a little more financially sensitive. And I think those are super important. Any protections that you don't have, and I will tell you, community hospitals don't have a ton of leverage always to get them, is figuring out what your value is around that, understanding what you can get from a payer and what can they do to make you feel a little more whole. And again, a lot of this is talking through the problems. It's really understanding your value. When you don't have a ton of leverage, that can be incredibly hard to do, especially if you're trying to get rates that seem more fair than where you are today. I don't have a golden ticket for it because I think each community hospital is different based on where they are. I will say that on the provider side, the professional side, where I have a whole bunch of clients all over the Northeast, there's been some interesting there. Typically, it's showing what's your value. Your value is you're cheaper than a hospital. And depending on whether you're behavioral health, pediatrician, dermatology, and I have a great story on that one, but really understanding where you fit in the grand scheme of the payer's unit cost. And I know that's not the focus of a hospital. Total cost of care is super important, but if you're just a dermatologist out on, let's say, Long Island, you're not necessarily affecting total cost of care that you can measure, but you actually can measure yourself relative to other dermatologists or what it means to go to a large medical center for the same exact procedures. And that's a really important part to position yourself in the market. Also, it's really important if you're a smaller provider, if you have the ability to take Google reviews, if you have the ability to push patients who come to you to talk about you in any sort of way, especially online, that can be an incredible boon to your business from a perspective of negotiating. And if you have really good patients and they really love you, again, I can talk about the strategy. I'll wait for that, but I'll give you the story that one provider did, which was fantastic, and mobilized patients. And he's one of the smaller practices out there.
Great. Just throws up, any of you can answer this. Also, when it comes to assessing your situation, do you probe for information internally? So for example, do you want to find out, and it's almost a leading question. You want to find out, I'm assuming, from Rev Cycle, from from finance, where's the abrasion? What's happening, right? To get a full picture of what's happening, both what you want to achieve, but what you also need to protect against. So that's been my experience as being a managed care attorney and trying to protect the providers. I always want to know, what's your denial rate? What are you seeing in that would be Rev Cycle? Again, where's the abrasion? Are you getting turnaround? Are things getting stuck on getting authorizations? That actually impacts everyone. So I always counsel clients, make sure you know where the problems are so that we can address them when you're sitting down with the payer. So let's go on to developing that negotiation strategy. So I threw out a couple of leading questions here as to what you do. So we don't have to go in this complete order, but let's start. And this time, Kwynn, I'm going to start with you. How do you prepare for rate negotiations?
We start 18 months in advance. In driving the analytics, driving the in where we are in the marketplace, with our facilities, with our physicians, from a rate perspective, we start to review, as you just stated, Deb, the areas of friction, the areas of dispute that are occurring with the payer. We start to really refine them and work with the payers through JOCs to see if we can resolve them. We want to vet out where and when, we need to correct our contractual relationship in terms and conditions. There is the old adage, what the left hand will give it, the right hand will take it away. So if you're not protecting yourself in your language, you're at a high risk level, from my perspective, in having revenue erosion. And any revenue increase or rate increase that you're able to negotiate will be dramatically eroded over the term of the agreement unless you build in those protections or triggers for protections of that. These bullets are, yes, there's rate negotiations. There's language negotiations are as imperative as your rate revenue negotiations. Language is always on the table. But language is, the language part of a contract we view as it's a living, breathing document, and it's got to consistently be reevaluated and renegotiated as you're disputing the terms and conditions with the payer compliant in that. When payers send a new contract template, that's always a long, exhausting process.
You don't always have to say yes to a new
No.
template.
No, that's
That's
why it's long and exhausting.
Yeah, it is. It is. Question though, Karim, when it comes to rate negotiations, what impact has price transparency had on rate negotiations for you?
Well, everything became now an open book negotiation. I mean, it's just, it got harder and harder. So I agree with all Quinn's points here. You got to start early. You got to determine first what kind of inflationary rate increase you're looking for to cover your cost, right? You need to conduct market intelligence using transparency data. You need to compare your rates to your competitors, other health systems. And as well, you need to compare your rates of the payer you're negotiating with compared to the rates of the other payers, because it's a two-road process here, because even you might not be you don't have the highest rates in the market, but if their rates with that payer X is they're higher compared to the other payers, you have an issue too during negotiation. And that's important, so that market review would let you anticipate how the payer going to position their arguments, right, before you start engaging with them, and be able to come up with answers around that. And that would help you too to determine how much of that inflationary increase you want to put into the rate versus a P4P program or a value-based contracts. So there are kind of three different sources of revenue. It comes from rates, it could be from P4P or other value-based contracts. Critical language issues need to be brought to the table and should be addressed, part of the rate increases. Some of those items, policies, might have a very significant value, and it will be the right time, if they are important to you, to trade them in for taking a lower rate increase or less on some other P4P program. Any disputes that are lingering, as we've seen, Deb, over the last 2-3 years, it doesn't matter. You might have the best contract language. The payer do not abide by them. You keep going back and forth. You can even go and sue them even, and still not resolving anything. Once you engage in a contract renewal, it will be the right time to try to resolve those at the same time as well. And in terms of a new contractual template, what we've tried to do here, if you have good language in your existing agreement, is you need to push forward with transferring that good language into the new template. And what we tried to do during negotiation, negotiating rates alone is very hard to do. If the contract language is up for renewal, we would agree with the payer to do those like within 120 days following agreeing on rates on a prospective basis. And then it has to go through negotiation of what they can work with and what they cannot. In some instances, some payers are willing to make exceptions to certain things, but they're not willing to keep it in the body of the main agreement, and it's done usually by a side letter or a side email.
Deb, could I add one point to,
Sure.
So I think Karim really brought up a strong point, and I want to highlight it. Parity in your rates and language across payers is critical to us. Not having parity in how you're being reimbursed and in your contract language really ends up in market driving of membership. And that is a major concern of ours.
Could you elaborate on that, what that means?
Well, if you have payer A who has a 10% differential lower rate, and significantly better terms for them on reimbursing you, they will be able to monetize that and also sell that through a rate differential in the premium, and show on the ASO clients a lower per unit cost and a lower savings, and you'll see them grow in the marketplace, which is, I'll quote Drew Swiss, we're cannibalizing ourselves then.
It's true. We've seen this over the years.
Mm-hmm.
I will get to this, but I just want to say when we talk about language, as your lawyers, I am able to draft language. You need something, I can draft it. The problem that you have with language is that you need to be sure that even if a plan agrees to it, one, they can operationalize it, because we have encountered on more than one occasion great language that for some reason when a claim is not, it falls outside of it, you're not protected, and then you're constantly playing catch up. So I always want to be sure at this stage of the game, given that we're, in managed care contracting 7.0, whatever we're at, that the payer can actually do what we're asking them to do. Because I think one of you said it earlier, probably all three said it. There's not a lot of shame anymore when it comes to a payer if they don't adjudicate claims and follow the terms in accordance with the terms of the contract. It's just something that they seem to say is, easier to ask forgiveness than permission. So I do like to try to make sure that whatever language we do get, it can be operationalized. All right, Jeff, from the perspective of physician group.
Yeah. So I won't talk too much about hospital. It's the two. I can't top that. I have had some of that. Monty and Drew Swiss was also my boss, as he was Kwynn. So learn from the best. So what they said about hospital, it's absolutely true, and it's incredibly complicated. I represent small to mid-sized medical groups, and on that side, on the professional side of my business. So I will tell you, they have zero leverage, number one. Number two, parity. Rate parity is super important, not because of because the rate parity for a small provider is not going to affect how they sell a network, but it does affect how Northwell, NYU, Mount Sinai, they get Monty, those rate parities are super important. Why it's super important for a provider especially if they're unbalanced in a market where they have two dominant payers, is if you have a really unbalanced there, those companies oftentimes trade all the time. We see these groups go from one to the other, and I know, Kwynn, we've seen this in the market in New York, and I know you guys have both seen this. That can be a really big difference because overnight, if you have a payer that was 30% higher, and I've seen this, overnight you're losing 30% revenue, but you're offering the exact same service you were before. So one of the things about developing a strategy for me is I walk in, and this is a majority of the time, the first time they have ever even thought about how to look at their contracts, because they don't know how. They don't have someone like me on staff because they can't afford it. They don't have a Deb Silverman or one of the 3 very big law firms here in New York or others to be able to have that protection. Some have invested, but very few can afford it. And when they get to, by the time they get to me, they don't even know where to go, who to talk to, what to do. They don't even know where to start. So that's easy for me in that sense because I can get to everybody. New York's the easiest. It gets harder as I leave my market, but I have been successful. Same strategy. The strategy is simple. I gotta have your data. I will tell you small medical groups, and I know this, you guys, you still struggle with data. You'll always struggle with it. But some of these small groups have never even thought of the data the way I look at it from a unit cost perspective. And so the first thing I got to get on the table before I even take a client, I actually look at their data. I don't charge them a thing. I look at everything and say, this is probably not going to work. So I don't take money for nothing. I can only get in negotiations that make sense. But if I have the data and I see where they're down, and I actually, thank goodness, have some access to transparency data, I know where they stand. And then I also look at their, what are we going to say? That was the first time. What's the value prop? If those are all both there and there's a viable rate we can get to, I take that on as a client. Developing language, there's a very, very low chance they're going to have language. But I do look and try to understand any denial issues. These aren't huge on the professional side. They can be very specific verticals. But as it pertains to like a pediatrician, for example, there's about 20 codes they bill. It's not a denial issue. It's really just they're doing a lot of work, and PCPs in general, pediatricians specifically, tend to get paid sort of the least unit cost. And there's a value prop here, depending if you don't work for a big firm, you don't have a big hospital. So I use all of those things to start building up the provider to say, hey, you actually are offering something here. For example, very small provider in the Pennsylvania market, pediatrician did not want to join the big guy. I use that as my smoking gun because she was about to. She happened to have extensive training in pediatric behavioral health. I think everyone here who knows anything about the access to participating providers for a commercial in the pediatric behavioral health space is very limited. And PCPs and pediatrics have been asked to do this. To get the training, they have to pay for it. To actually get a quick assessment. So that's a value play. So again, it's part of understanding what strategy you can bring to a payer. Was I successful? Yes. Did I get the amount that I thought she really deserved? No, but she would have gotten 0 otherwise. She actually was an incredibly small book of business. And one of these payers came to the table and said, we're still going to give you an increase, even though they could have said, you can leave, we don't care. So there is a value in understanding what are all the things that matter for a small group. And it's very different than what NYU and Sinai have to deal with. The complications there are beyond, but this is more, do we have a chance? And most providers, believe it or not, do have the opportunity to get something. And if they get 2%, it's there forever, right? So we'll talk about managing expectations, obviously, is the next. But in terms of language, I would say not a huge part of that business model on the professional side. It really is all about rate and positioning yourself and really knowing what you're, again, leveraging the market and strategizing what you're going to tell the payer. One other big key point here, like Kwynn and Karim, who are a lead and have a team of people who are very experienced in how to speak to payers, I will tell you, depending on the position, and not all, but most, they're not necessarily the etiquette, the how you talk to a payer, getting the emotion about the fact this is your practice, and that is a very, very important part to me. And I usually communicate with whoever I sign this contracts with, please, unless it's necessary, I'm going to not have you involved in any of the email communications or phone calls. I will say that that's a part of a strategy that works really, really well because it takes the emotion out. Because then I get to take the brunt of both sides. And so anyway, that's another part of the strategy for a smaller group. When you bring in a consultant to try to really, they like consultants, especially. That's another thing to talk about. They love that you can speak their language. And I think that's actually a huge advantage when you bring in someone like a PMCC or others.
Let me just add something to that you were touching on, but I don't think you said it outright. This is a relationship business. I think all 3 of you will agree. You know people, you develop relationships, you always keep it cordial, even sometimes in the most fraught negotiations. And that helps. It's harder to say no when somebody likes you. And I'm not saying you have to suck up to anybody, but you need to know your stuff. You need to understand where they're coming from. The most important thing to a payer, and you guys can tell me you agree or disagree, is that they want to sell their product. That's where they make the money. They certainly don't make it paying providers. So whatever we can do to keep things friendly, cordial, and substantiate what you are asking for, especially when it comes to language. I always say, do you have an example of how that language that you're looking to change has hurt you? And so I think that's something that even the smaller guys, if there's a provision in there that you're, I don't know, the ability to amend on notice. I mean, there are certain things, there are some laws like New York State will protect a provider, a professional, not an entity, but a professional from unilateral rate increases. You have to get 90 days notice if it's a fully insured product. And then, but your only option after that is if you don't like what they've done to your rates, you have to accept it or leave the network. So it is tough out there, but you can do things, as you're saying, that can put you in a better position. Let's start with managing expectations internally, because everyone needs, you guys are being hit from all sides. We need to increase our revenue. You know, go out there and get me 15% rate increases across the board if I'm your CFO. How does that work?
A lot of managing expectations goes to the first part in doing your due diligence in setting up the negotiation and in setting up what your ask is going to be. You need to come in with a very extensive structure on revenue increases, where I'm going to put my revenue increases, both facility and professional, and in your IPA if you have an IPA. So you need to set out what our ask achievement has to be, and then really what your BATNA is, which is best alternative to no agreement. And you need to set those out to what we can live with if we end up terminating, or we end up where we don't want to have a termination. Those have to be pre-established prior to you entering into any negotiations, and they have to consistently be reevaluated, dependent upon the payer, the products, and the lines of business. Maybe you have to shed a line of business here and there with the payer. Participating with the payer for all lines of business, I think, is an old school thought process today. So setting out those expectations, and establishing them and having them agree to prior to entering the negotiation is critical.
Karim?
Yeah, I agree with all Quinn's comments. What I try to do at NYU to in setting internal expectations is we have a group as we're gathering information early on before we kick off the negotiations, even though we start them at least a year with the payers so we don't run into any delays. They never materialize on time. The payers engage whenever they're ready to engage. It is always managed care, finance, senior management, educating them where our contract with that specific payer we're renegotiating in terms of its value of business, where the rates are, as I covered earlier, compared to the competition, and so that we can determine what's a reasonable rate increase we can extract from them. And once we start the negotiations and we see, so in our mind, we think we should get X percentage point, should be an easy, and that payer is starting because they look at transparency data and they incorrectly analyze the information or modeling it, and they come and say, oh, I want a 20% decrease. Then we call them to a face-to-face meeting and showing them masked information where the information is incorrect and try to steer them correctly. And we saw that kind of work effectively rather than exchanging just rate proposal. And several of them are appreciative relative to what we showed them they might have done wrong when they analyze the information, and try to set them back on the right track so we can have a productive conversation rather than leading into just termination abruptly for no reason here. And we were able to save few negotiations that way.
Jeff, I think we're gonna, I think you've touched on how to manage expectations when you're dealing with a smaller practice or a community hospital. Anything you want to add? If not, we can move on to negotiating with the payer. I don't want to run out of time.
No, yeah, just very quick point that, and Karim said it perfectly. Like the first thing I do, especially professional, I said, this could take 6 to 12 months. It seems irrational when you're talking about a $300,000 group or if like in total revenue for that payer. It just seems crazy, but that timing is so, so important. And then one other thing that we've done in my practice when it comes to the community hospitals, coming in as consultants, usually the first time is that, I'm still newer in the market, but like with the payers, I'm not, but with the client, we will set a meeting before we even drop a proposal and get with the payer to kind of lay out, here are the things you might expect to see from us in the next month as we go out. I don't think that's that different from what the big hospitals are doing as well, but we make it a point to get on a call face to face, like this, to make sure that they're going to expect what we're dropping in front of them. And, as you know, we have put the proposal on the table first, usually, typically, not always, but mostly. And that's really important to us because we feel it establishes, hey, just don't be surprised. And I think that's helpful in developing a relationship because I have less leverage than some of the large hospitals. So I think that's the one I want to say about managing expectations.
Let's move on to negotiating with the payer, which is where all the process that you've done, all the work that you've done to get to the table. One thing Karim mentioned, and I'm not sure if he's still having technical difficulties, but we're going to continue. When it comes to negotiating with the payer, you set a meeting. Zoom, WebEx, Teams versus in-person. What are your thoughts? Kwynn?
We prefer in person to kick off the negotiations. As Jeff said, and I believe Karim would support, you're presenting your case. You're presenting what they're going to see in your proposal. You're presenting the legacy information. You're presenting where you are in the marketplace. If there's disparities where you are in the marketplace or disparities where that payer is in the marketplace, or just where the payer may be not acting in compliance with the contract, you're going to point those out and have those conversations. You really want to have a level setting meeting about what your expectations are coming out of this negotiation. And it really can, hopefully kick off a fruitful and expeditious negotiation. I will say from my own experience, I just see the usual delays. Payers want to delay and shorten the time frame for negotiation. And they want to push it to where it's really pushing up against the negotiation strategy. I mean, the negotiation time period. You have to be ready for and communicate. I'm ready for a termination.
We were just talking about whether you should have an in-person negotiation or do it on the screen. I guess it's preference per entity. Who do you like to have at the negotiation table, though? Do you like to start the negotiations with somebody more junior to yourself so that you can come in later and say yay or nay, so that it builds in some flexibility for you? Or do you think it matters that you're at the table from the get-go?
Well, I'm kind of guy, I could tell you, I always liked starting with the junior people, and it worked effectively many years ago. you know, but today it's just hard sometimes to start there. You want the person at the top to be at the table, and it depends on the payer you're dealing with sometimes.
I would echo what Karim is saying. Depending on the payer, the authority has rolled up, and so you have to make that assessment based upon size, how important you are to the payer in the marketplace, but it's also who that, you know, how that payer is operating today and the local authority they have. That authority has been dramatically consolidated in the BUCAs. So you need to have somebody who has some authority at the table from the onset.
Okay, for those who don't know what BUCA stands for, those are the Blues, United, Cigna, and Aetna. They are fondly referred to as the BUCAs.
Yeah, it might be changed to BUCA-E soon.
That's for New York when you
In
add
New York,
emblem.
yeah.
Yes.
When you add emblem. So it's as
Well,
honestly,
it'll affect other parts of the country depending on New York City retirees.
we're still waiting to see how
Kwynn,
that's all going
we
to
don't
come.
have another 45 minutes, so we're not going to touch that.
I'm just throwing in something for our
But he's right. He's right. Let me just,
Carolina and Florida.
so coming from the payer, having been at United, where I spent a lot of my negotiating, where I learned a lot of this business and represented and ran the physician network effectively for the downstate market. It's really important. Kwynn brought up, I think, what's we've seen happen, and it happened fast. And it happened why some of the best people I know ran out of these places to go and where they could actually affect change. And so, to his point, you could be a VP of network at United, at Anthem, whatever, and you would go to try to, say, here's what we need to do, kind of have it's your providers. No, it doesn't work that way. And I mean, we saw this when I was at Montefiore when we went through our situation with a payer, and it all goes to the highest levels. The lowest, like I would say, folks that even reported to me that are still at these companies, they've been left with, here's the healthcare economics now runs the show. And so they'll say, hey, here's what you can offer. No matter how good your relationship is, this is what you get. So what I would say to that is knowing that when the providers, let's call them the smaller ones, and I would say even my community hospitals also don't get we're not at the level where Kwynn's going to get to or where Karim gets to. We're still getting people who don't have a lot of decision power, but the relationship management, some of these, I say younger folks that have come in haven't been trained in the ways that like Kwynn and I came up with. We haven't had that. And so you have to sort of tenderly speak to them and respect that, look, they are going to do what they can do. And I think setting yourself up on like these calls, I don't get to do in person a lot. It's very, very difficult in my business, and they're not going to spend the time or money to do that. It's going to be difficult for me to have the client pay for me to do that. So what I end up saying is let's get on a call. I'm always on screen. I find that is a huge strategy. What I find is about 50% of the time, the contract manager, and that's the time I don't get to go to the VP. Sometimes that's how I get to that person, but they won't even come on screen. I don't even see what they look like. And so there's a definite difference, and you have to just respect that is that's it, not feel insulted. It's a very humbling thing to think through, like as an former executive of a health plan and a hospital, and it's to say, hey, look, everyone's just a person out here, and that strategy is what we do at PMCC, especially for smaller groups, is not try to demand the highest person, because that isn't necessarily the route, and never go around somebody that's on your account without literally, can I work with your manager as well? So there's a respect, and I think that's a part of it. I know that's strategy, but it really is part of the process I'm finding, and I'm getting better and better at this as I get more and more clients, and as I leave New York. It's even more so like that. There's like zero decision power. The staffing models are much different. So I think it's a really important point what Kwynn brought up.
Okay, thanks, Jeff. Let's move on. We're running out of time. I want to just hit, like when you hit a wall, and what happens when things go bad. So we're going to hit, I don't think we'll have time to hit all these questions, but let me start by asking, what do you do? I think to me is, when do you know when a payer is posturing or when you know that no is no? Is it easy to determine? Is it sometimes you don't want to feel that you're being taken advantage of? So Kwynn, if you could just spend a minute on kind of reading the person across the table, whether it's in person or on a screen. When do you know that you need to like back off of a particular, well, let me rephrase that. Do you have your list of must-haves? And then you have your list of it would be nice.
Always. When you're getting to those final points and you have open items on your must-haves, and they have open items on their must-haves and will not gives, you need to go face to face. You need to be able to read body language. You need to be able to see the posturing. You need to be able to reduce the number of people in the room, so more transparent and honest communication can occur. And then you assess that and internally deliberate over, okay, what can we alter and what can we live with? That's where you're getting down to the BATNA, best alternative. You're not going to get all of your must-haves. You never. But it's a process. It's a time. Negotiations it's over cycles of negotiations.
You take the wins where you get them and
Yes.
live to fight another day. Karim, I drafted number 3 with you in mind. I mean, you've been around a long time. You've got long-term payer relationships. Is there some sweet spot that you try to balance the existing relationships with making sure that you get what NYU needs?
Yeah, I think the most important thing when when you're negotiating, you need to keep it on a professional level. Don't get it to a personal level because things are much tougher. I've been doing this for a long time. I mean, negotiating back in the 90s and early 2000s, much easier, obviously, than now. It's all about, the payer having to maintain the credibility and honor what gets negotiated. There's no point of you agree on a certain percentage rate increase and tomorrow they take it away by pushing a new policy out. So basically, enforcing the managed care contract is very important and requires constant monitoring of any changing pushed by the payers and anything that have material financial impact or increase your administrative costs, you need to act quickly, to notify the payer, according to the terms of the agreement, especially if there's time frames, you have to notify them so you don't lose ground. And you need to do that by certified letter, email, and be able to quantify the financial value of that thing and the implication. And if not resolved, you need to leverage legal counsel like you did, right? And figure out what are the terms of the agreement in terms of the legal escalation. Do you go through contract dispute resolution, ADR, arbitration? Some contract might have binding arbitration. When can you litigate? And then if all of that fails, and this is something big in terms of financial implication, can you qualify that as a breach to the agreement? And then are you willing to threaten termination? And as a health system, are you willing to take that step? And if it's a governmental contract, you should pursue regulatory remedies by reaching out to CMS or state Medicaid. And if it's something, bad, but not as bad, you might have to live with it until the next round of contract renewal until you deal with it. If the payer is not budging, what I find it is having a good business relationship, trying to resolve this between parties is the fastest way of getting things done. Once you have a lawsuit in place, it just nothing gets done, and it's a very lengthy process.
I think we're going to have to leave on that note. We are out of time. I thank you all. This was terrific. And if you have any questions, this is being recorded. Type them into the chat. Hopefully you've been typing them in as we go. And I'm on, and I think Kwynn is going to join us, and we'll see who else can join us during the actual presentation date on the 29th, and we'll try to get back to you. So thank you all again, and have a great day. Bye now.
Thanks, Deb.
Right. Thank you.
Thank you.